So without wasting much time, I will speak to a presentation on tuberculosis. And TB is a very interesting, next slide. So this is the presentation outline, and as you can see, it's really packed, and it has lots of issues that I wanted to share with you, current statistics, current dynamics around TB, and this is one of my passionate areas. I was an advocate for TB when I was only grade 2, when my father was diagnosed of TB. He was working in the mines in Kwekwe at Globe and Phoenix in Kwekwe. So he had a bit of a challenge, and he got TB, and you know, in the mines, you get to be exposed to TB because of silica dust. And so when he got TB, it was during the colonial era, and then he couldn't get access to services because of the racial situation that was there. So I became an advocate for TB then, and I'm still an advocate for TB from national level to global level, because that's when I went to a private hospital that was in Kwekwe, and then I slept at the entrance, and I told them, until you treat my father, I'm not going to leave this place. And I was only grade 2 by then. And up to today, I continue to engage in this discussion. Last year, I represented Zimbabwe at the United Nations High-Level Mission, where I presented before the heads of states, then signed the declaration, the first ever declaration on TB through the United Nations High-Level Mission. So why talk about TB to the congregates? We talk about TB because for you not to contract TB, you should just stop breathing. And I'll say that again. If you don't want to contract TB, stop breathing. So what it means is everyone and anyone can have TB. Tuberculosis has plagued the world for centuries. It's a century-old disease, and it kills 3 people every minute. So the minute that I've just talked, it has killed 3 people. That's global statistics. The cause that caused TB remained unknown until 24 March 1882, when Dr. Robert Koch announced that he had discovered the Bacillus mycobacterium tuberculosis, an event that is now commemorated every year. So every year on the 24th of March, it's World TB Day. In Zimbabwe, we commemorated World TB Day in Mangwe, in Matebele South. That's the National World TB Day. On the we delayed a bit, and we commemorated on the 27th. But the World TB Day is the 24th of March every year. So tuberculosis is an infectious airborne disease caused by that mycobacterium tuberculosis. Tuberculosis affects any organ of the body. However, it commonly affects the lungs. But there are 2 types of tuberculosis. There is pulmonary tuberculosis, and pulmonary tuberculosis targets the lungs, right? And extrapulmonary, it targets any other body organ. Every year, 10 million people, including 3.2 million women and 1 million children, contract tuberculosis. It's sad, isn't it? In 2015 alone, there were an estimated 10.4 million new incidences of TB cases worldwide, of which 5.9 million, which is 56%, were among men. And men always say they are so strong, and our health-seeking behavior is not so good, as well as our help-seeking behavior. And it adds to the grief, because we don't reach out easily for help, neither do we reach out easily to seek health services. 3.5 million, which is 34%, were among women, and 1 million, which is 10%, among children. Next slide. In Zimbabwe alone, coming back home, because I was speaking to the global statistics, and you might say, no, that affects some other people somewhere else and not in Zimbabwe. In Zimbabwe, out of a total of 9,084 clients in 2014, I use statistics for 2014 because that's where the National Prevalence Survey was done. So it's from the National Prevalence Survey statistics. So TB accounted for 13% of the deaths. People living with HIV accounted for 1.4 million. Current statistics is 1.4 million of people living with HIV. It can be more, but we'll get to know future statistics when the new demographic health survey will happen. But 11% of all new TB cases came out of the 1.4 million people. An estimated 37,000 people developed TB annually. That's in Zimbabwe, of which only 26,401 are diagnosed and reported in the system. As you can see, it's not a good picture. But 30% of those that have TB in Zimbabwe are missed within the cascade of care. And as we're missing 30%, you can count the numbers that are here, and 30% of the congregates can or might have TB and might not know that they have TB. That's the reason why we have to discuss TB, because it is also known as the silent killer. Significant treatment success in Zimbabwe is currently stable and is at 81%. Significant variations, as you can see on the map, there are variations, provincial variations with regards incidences of TB. But the greatest, those areas that are in red, are the ones that have serious challenges, and Matabeleland and Midlands are among them, with Matabeleland having 19% in terms of accounting for the burden of TB in Zimbabwe. The prevalence rate in Zimbabwe is 343 population per every 100,000 people. So 343 per every 100,000 is the current prevalence rate. But this is from the prevalence survey, which focused on the general population. It didn't go into the prisons, neither did it go into the high population risk groups. 287.6 women, that's per every 100,000. Zimbabwe is among the top 30 high-burdened countries in the world. And it's a multiple burdened country, and multiple in the sense that it is affected by TB as TB alone. It's also affected by TB and HIV. It's also affected by multi-drug resistant TB. So we are in serious trouble. As you can see, we are here as Zimbabwe, in the middle and in the center with these, the TB, HIV, and MDR TB. So we're in serious trouble as a country. And childhood TB has been accounting for 7 to 8% of annual notifications in Zimbabwe. And HIV, TB, morbidities remain the major burden in TB. So a person with HIV is more prone to have TB. Drug-resistant TB notifications continue to show an upward trend, and drug-resistant is a serious condition. We'll speak to that as we go through the slides. TB burden in children and adolescents in Zimbabwe. In 2017, 1 million children between 0 to 14 years developed TB. 52% were under 5 years. 233,000 died of TB. And every day, 650 children die of TB. And TB is often missed in children, and MDR TB even more often. And why it's often missed in children? There are also dynamics around consent, or dynamics around equally the availability or the proximity of facilities to children, because without a consent or without a parental consent, children then don't automatically get screened or get access to services. Remember, the age of consent in Zimbabwe to access to services is quite a topic of discussion in Parliament around reducing that. But I know of late it was being misconstrued around age of marriage versus age of consent to access to health services, where there was a motivation to reduce the age of consent. Remember, if your child wants to go and get tested, they have to have parental consent before they get that testing. So that then affects the issue around children. So as you can see on the graph, the percentages of TB patients that are missed in different age groups, you can actually see that the under 5 years here, in terms of those that are missed within the treatment cascade, is 69%, right? And then between the 5 to 14 years, it's 40%, and all other age groups, it's 35%. And in terms of the national cases that are notified by age, as at 2018, that's the last year's statistics, you would find the 0 to 14%, the 0 to 14-year age group, it was 6%. The 65 and above, it was 9%, but the 45 to 64 was 23%, and the 15 to 44 was 62%. That's in terms of the age groups, in terms of how we are affected. But again, if you look at MDR, next slide, if you look at MDR TB, you would realize that to 0 to 14 years, we have those that are 25,000, which is 10%, that have been diagnosed and are accessing treatment in the country. The next slide is quite a busy slide, but it will just give you information that I was presenting in a summarized version. So you'll get to interrogate this more when you get these presentations. So it pretty much summarizes the epidemiology, the Zimbabwean epidemiology around TB in terms of those that fell ill and that presented to facilities, the deaths, 8,300 deaths, as at 2017. These are the statistics as at 2017, and you can actually see the TB, HIV comorbidity rate, and then the rest of the statistics that are in that slide. So I'll skip that slide as it summarizes what I've presented. I'm trying to manage time and task. So next slide. Next slide speaks to the treatment outcomes by age, so that you don't despair. You know that TB is a disease that can be treated, right? So because it's treated, the reason why people are dying, because there are issues of stigma and discrimination, there are issues of health-seeking behavior, and there are issues, there are so many other dynamics that then come into the picture. But TB can be treated. And this slide then brings you statistics around treatment outcomes by age and by province. I'm not going to speak to all the provinces. I might zero down just to Midlands and Masvingo, some of the provinces that are represented here. And in terms of Midlands, in terms of treatment outcomes, those that have died, 11% died. That is as at 2017. That's in Midlands Province. But then, in terms of treatment success, there was 83% treatment success as at 2017. And for Masvingo Province, 6% died, and there was 90% treatment success. So the success rate is very good and encouraging, as long as we present early, as long as we are screened early, and as long as we present to facilities early. But then there are those that are lost to follow up. So those that are lost to follow up, remember, we have relatives that come into the country and go back to South Africa. They might be working in South Africa, but they come back and access services here and then go back. So you find there are others that are lost to follow up because they moved from one district to the other, and quite a number of different reasons for the lost to follow. The next slide pretty much looks at the death rate for all TB cases is between 2010 and 2015. It's equally a busy slide, and you might not see it from afar, but I'll equally look at the Midlands and the Masvingo statistics. I hope I'm doing justice to representation in terms of those that are here. But you can interrogate the slides later on. In terms of Masvingo, you'd realize in 2010, we had 17% in terms of our death rates, but it went down to 13%. And I know the current statistics were going down for Masvingo province as it last year. But for Midlands, you'd realize we have a significant high variation where the death rates are going up. In 2010, we were at 8% as Midlands, but currently we are at 12%. That's as at 2015, but the rates are equally going up, and Mrs. Shumba can attest to that. And the reasons that this is happening is we equally have high-risk population groups in the Midlands. We have the artisanal and small-scale miners, commonly known as Makorokozas. We have quite a number of activities that sexual-related activities and lots of other activities that also present hotspots within the province. The next slide summarizes the drug-resistant TB treatment outcomes as at 2014. The reason why I'm sharing these statistics is so that you get to know that these are not just numbers. These are people, right? Because at times when we interrogate statistics and we think, my statistics teacher used to say, statistics may sound pedantic, but it only means numbers. But then when we then come to reality around tuberculosis, they are not just numbers, they are people. So we're talking about people. And among those people, our relatives. In terms of drug-resistant TB, the total number of cases that were registered in 2014 were 381 and who were initiated on second line. So drug resistance, I'll speak more to what causes drug resistance and what then comes into the effect. But those that died because of drug-resistant TB were 66, which is 17%. Those that failed treatment were 6. These are absolute numbers, and which is 1%. And those that are lost to follow is 21, which is 6%. And it's not looking good. Because remember, this is 2014, and from my earlier presentation, we said the drug-resistant trajectory is going up. So as it is going up, the figures are going up. And as the figures are going up, we are losing our communities, we are losing our relatives, which is not good enough. But how is TB transmitted? That's the next slide. So the mode of transmission is through air. Remember when I said, if you want not to contract TB, stop breathing. Why? Because as you breathe, so it's through the air. Person-to-person airborne particles called droplet nuclei are generated when a person who has pulmonary TB coughs, sneezes, shouts, or sings, depending with airflow. They remain suspended in the atmosphere, and anyone who breathes this may contract TB. And I'll underline may. Yes, it doesn't necessarily mean that everyone will contract TB. So the factors that influence transmission, number one is susceptibility, your immune system, right? So the immune system of the exposed. So if you look at the high-risk groups, they have a higher percentage of being exposed because they are high-risk groups. Then infectiousness. So the number of bacteria that's expelled by an infectious person. And then the exposure. Duration, proximity, and frequency of exposure. So it becomes important that for the high-risk group, there is regular screening, because the minute you start treatment, the minute you then stop to transmit, because it's easy. That's the formula. The minute you start treatment, you stop transmitting. But the moment you continue not being on treatment, the more the challenge. And again, environment. Ventilation and lighting becomes key. If you get into a room, ensure that it's well ventilated. But at times when we get into combis and we get into buses, we want to close the windows. Do you see how we are exposing ourselves? Then there is the not so rare type of mode of transmission. In Zimbabwe, it's not so rare, which is animal to human. So it's called zoonotic TB. But zoonotic TB in Zimbabwe is not rare, but there are animals that die because of TB. Did you know that? And that's zoonotic TB. So this also comes through ingestion of my mycobacterium, which is called Mycobacterium bovis, which is found in unpasteurized milk, undercooked meat, and related products. So that's zoonotic TB. Next slide speaks to the high-risk groups for TB in Zimbabwe. Malnourished people, children under 5 years, people with medical risk factors. Diabetes is one of them. And it's important for people with diabetes to continue to have regular screening. Kidney diseases and receiving immunosuppressive treatment. People who smoke and drink excessive alcohol. But it's just being polite. People who smoke and drink. Full stop. People living with HIV, contacts of TB patients, current or former minors, formal and informal, healthcare workers. You also need to sympathize with healthcare workers because they are highly at risk. Elderly people, so those that are above 65. Prisoners and prison communities, people living in refugee camps and other congregate settings, people in poor, overcrowded communities. And the last one also brings in a component of stigma and discrimination. I'll speak to stigma and discrimination in the afternoon because TB then is also then known as the disease of the poor. And if you realize, if you go back to that previous slide where I talked about the 30 high-burden countries, you would realize that they are not so wealthy. Next slide speaks to the signs and symptoms of TB. And as the pictures show, coughing for more than 2 weeks, night sweats, fever, weight loss, shortness of breath, chest pain, loss of appetite, and fatigue. But there's a but. You might have latent TB, and you don't present with all these symptoms, but you might still have TB. So it's important that you are regularly screened for TB. I'm not going to speak to diagnostics. It's pretty much what is used, but Zimbabwe adopted the GeneXpert, and we're also equally using the chest X-ray. So we are moving as a country with technology, and quite a number of treatments. The next slide speaks to treatment. The latest and developments in terms of research and development around TB. For close to 100 years, we continued to use the same drug regimen in the world. But then thanks to new developments, we have latest drugs, pedaculin, we equally have delaminate as new drugs that came in 2017. So in terms of treatment in Zimbabwe, treatment for TB is free. But of course, there are costs that you incur as you present to facilities before then you become a TB patient. But in terms of the medicines, TB treatment is free. So there is no reason not to seek for treatment. We'll move on to the next slide. But I'll also talk about the other hidden costs that are there. So just during the World TB Day, a patient survey or patient cost survey was launched. The results of the survey were launched, and I'll also present the results of the survey in terms of the costs that then affects TB, and those costs then become barriers to access to services. In terms of care and support, I hope I'm still good on time. So in terms of care and support, thank you. And this is also where we have a role as a church. where we need to come in terms of providing care and support. Adherence support is critical, because the reason why quite a number of patients die is because of lack of adherence. And adherence is that ability to continue to take in the tablets or the medication is prescribed by our nurses and our doctors. So it's important that we adhere to treatment. And the adherence, lack of adherence, is the one that then causes us to go to the drug resistant, because it becomes drug resistant because we have resisted the first line of defense. So now they have to take us to the second line of defense because we have developed resistance within our system. But counseling becomes equally critical because of the components around the huge package that we might be consuming. So there's a pill burden that also comes into the picture, the number of tablets that we're engaging in. But thanks to development, like I said, research and development, those are reducing and have reduced. But also a strong psychosocial support system is critical. And who then can provide that? The church should come in and provide that. The Mrs. Mashiris that also provide that service through passion, it becomes important. The NGOs and the various players, but everyone has a role in terms of providing psychosocial support, because quite a number of patients then die because of giving up. And that is related to mental health. They eventually then give up to say, after all, why should I just continue? This is just too much. And they think that they're burdening people that are assisting them. So it becomes important that as a church, we provide psychosocial support. But not only psychosocial support, we are supposed to provide spiritual support, which is critical. And these are essential through the treatment phase to prevent further infection and development of drug-resistant TB. Hospitals manage severe forms of TB requiring hospitalization. So when a patient is hospitalized, if we then don't visit those patients, then it becomes a challenge. Because we are not providing that psychosocial support. We are not providing the spiritual support. And eventually, the patient dies. And I remember one doctor saying, I see whether the patient will survive or die is we are pushing the trolley to the theater and I look at the person. If that person is smiling and has hope that I'm going to the theater and I'm going to survive, that person will survive. But if that person is kind of looking a bit, that person might not make it. And equally the same, when people visit you in a hospital bed and they look at you and they look aside, what was about shut. But then if they look at you and encourage you and smile at you and laugh with you, then they give you hope. So as churches, we need to continue to provide that support. It is important. Community-based TB interventions include health education and information dissemination. That's the next slide. Reminding TB clients to take their medication. Reminding TB clients to comply with review dates, providing psychosocial support, as I was reading through the church manual, is part of the deacon's duties to also do this. It's there. Are we doing it? Is the question. Are we reminding our fellow clients, or are we stigmatizing them? We need to remind TB clients to comply with the review dates. We need to provide psychosocial support. We need to provide resources, monetary and material. We need to refer TB clients for adverse reactions. If there are adverse events, suppose there's something else that's developing, we need to quickly refer them for further management. We need to adhere to infection control recommendations. Remember, I talked about ventilation. Remember, I talked about sunlight. Those are therapeutic. We need to form support groups so that they can share experiences, even as they relate with other TB survivors. And in terms of prevention, we need to screen, and we need to educate. And at times, there is need to separate. So that's where there is need to isolate patients for MDR, XDR, and like I said, at times. So it depends with how the nurses and the doctors look at the condition. If then it becomes highly infectious, it becomes important to separate or to isolate. Provide prompt health services. This is how we can prevent TB. investigate for TB or other diseases immediately as soon as you present with those 7 symptoms or as you do your regular screenings. But most importantly is environmental control measures. And this we can do and everyone can do on a daily basis. Maximize ventilation, keep windows and doors open. So cross ventilation. But in our houses at times you find the whole day the windows are closed. Right? And why is at times? Because we're moving with fashion and we're no longer putting the sun filters, or we used to call them less curtains. We're now putting those bigger, nicer curtains. So you say, I don't want to open the window because dust will come in, because you removed the sun filters or you removed the less curtains. Those are the ones that used to catch the dust. But it's important that we keep our houses well ventilated. Use of open air shelters, waiting areas with roof as you are waiting for a service. Control direction of airflow. Place fans strategically. Open plan that allows light in. As we are constructing our huge houses these days, there's competition for huge houses. But as we're doing that, let's ensure that the plans allow light to come in. And if you are serving clients within a constrained environment, ensure that you serve one client at a time. And the seating arrangement should be in tandem with the airflow. And I like the seating arrangement. The air is coming this way and going that way. So it takes away the infection outside. Avoid overcrowding. So these are ways where we can naturally, using our environment, control TB. But for those that are in a workplace, we need to wear N95 respirators, those that are used to ensure we avoid inhaling droplet nuclei. Good cough hygiene. Cough etiquette becomes critical. When you're coughing, you cover your mouth. So if you do it this way, then you know you're coughing. Or you cough in your jacket if you have a jacket. But the most important is you use your hand. Can you try that? Thank you. So that's good cough etiquette. So we need to ensure that you cover your mouth with your elbow or a tissue when you cough or sneeze. Then discard the tissue if you've used the tissue. Washing hands after sneezing then becomes important. Coughing or holding your hands near your mouth or nose becomes really critical. But routine TB screening is really, really important. For children, BCG vaccination at birth or at first contact with health facility is really critical in terms of prevention. Avoid alcohol, drugs, and smoking. I know this topic is one of the topics that are in our program. So it's important that we avoid those 3. Adherence to prevent drug-resistant TB. Infection control in households. I'll quickly run, my time is almost up. Early case detection and prompt diagnosis, adherence to medicines and advice, behavior change in terms of good cough hygiene. Like I said, keep windows and doors open. Spend as much time as possible outdoors. It's therapeutic out there. Home assessments to be done and adherence to advise is critical. And we have new technology for those that have HIV. We have TB preventive therapy where we have latest regimens that are faster, more effective, and they have less adverse drug reactions. So it's important that we quickly present to facilities or clinics so that we are managed. Contact screening and management is important. Avoid close contact with others, and bed linen and aeration in the sun is important. For those that travel a lot, it's important that you also ensure that as you're getting into the linen, you ensure that it's smart and it's clean. The next presentation is also a busy slide, but that presents, again, fast facts around TB and drug-resistant TB, but most importantly, it also talks about the comorbidities or the co-infections with HIV, with silicosis. I'm not going to dwell much on this to manage time. Next slide. next slide is equally talking about TB prevention therapy. It's important that those that have HIV are managed on TB prevention therapy. The next slide speaks to the new regimen that are available now. It's called the 3HP, which is shorter. It's a shorter course than the one that was there. So it's important that we engage in that. The next slide pretty much looks at drug-resistant TB, but I did speak to it. But drug-resistant TB is the in vitro growth of Mycobacterium tuberculosis in the presence of one or more anti-TB medicines. It can be confirmed through the lab and molecular tests. It's caused by a resistant strain of Mycobacterium tuberculosis, and it's precipitated or generated by human and system areas. So human, if you are not adhering to treatment, you then then become drug resistant. And if equally you are not responding well to treatment because of one reason or the other, that's self-driven. It can be self-stigma. I'll speak to that in the afternoon. Zimbabwe, I talked about it, suffers from a triple burden of TB, HIV, and MDR TB. And in 2015, 1,100 MDR TB cases were notified, and it's not good enough. And 433 MDR and 5 XDR TB were commenced on treatment. So you can see the disparity. 1,100 were notified, but 433 were only commenced on treatment. So which means we have a gap. And that gap is infecting others. And MDR is highly infectious. So of major concern is the fact that of all MDR cases, only 3.2% were new cases, and yet 14% were previously treated cases. And this is in Zimbabwe. It's not anywhere else. So the next slide summarizes in a pictorial format the causes of drug-resistant TB, but because my time is up, I'm not going to go through the presentation. TB is quite a long topic, and it requires more time, so I'll just rush through. I have almost 0 minutes left. Drug-resistant TB, I want to talk about XDR, that's the extreme drug-resistant TB, which is extensive drug-resistant. It's multi-drug resistant, that is resistant to any fluoroquinolone and at least one of the 3 injectables. So it's even much more serious than the MDR TB. The next slide, I'll skip that one. And it's pretty much unpacking extreme drug-resistant TB. And let me talk about the cost survey quickly because my time is up. That's the next slide. 4 of every 5 TB patients are affected households face catastrophic costs. And these are costs that equally then become a barrier to access to treatment. Continue clicking so that we have the full slide appearing. So in Zimbabwe, the current survey revealed that $150 is the average monthly income that's there within the TB household. And it's not, we use US dollars, but it's our dollars, our RTGS dollars. So as you can see, you'd find that 80% of TB-affected households face financial catastrophe, which means they are affected one way or the other because of lack of resources, of lack of income. But 90% of MDR TB patients face catastrophic costs compared to 79% of the TB patients that were also in the system. So you'd realize, next slide, you'd realize that the major components that relate to the costs are pre-diagnosis, the medicines that are required before you are then diagnosed, before you are put on TB treatment, which then becomes free. So you'll find there's an average of $15.7 that are spent on the higher level, and the lower level is $4. And in terms of radiology, because you have to pay that again on the lower level $5, and on the higher level 15.6. But consultation fees before you get to be on TB treatment, the lower side being 5 and the higher being 9.4. But indirect costs, even in terms of time loss, we have those. But post-diagnosis hospitalization costs, we are looking at a higher of $200 and a lower of $72. Extra food that you need to ensure your adhere, between $373 on a lower level, $240. Nutritional supplements that you will need, $192 on a lower level and $282 on a higher level. And transport for you to continue to access treatment, $33 on a lower level, $251 on a higher level. And then indirect costs, including time loss, $249. So it becomes important that we support, in terms of costs, TB patients. And in Zimbabwe, and in other countries of the world, MDR TB patients are then supported. Global Fund is supporting with the Bureau of Food handbags to MDR TB patients in the country. And in terms of poverty, the reason why it's called a disease of poverty, 71% of TB patients live below the poverty datum line. And as you can see, this is the picture. 71% general population, TB patients before TB, 71 TB patients after TB, 81%, which is not good. I would have loved to speak to TB in mines for those that are engaged in mining activities, but not only mining, but also cement, construction-related activities, because there is high exposure of silicosis. And I would have loved to compare, the next slide would have talked to TB in mines, but my time is up. It could have exposed the occupational hazards around TB, and equally, the next slide would have spoken to TB and silicosis. So there is a difference between TB and silicosis is as a result of the dust that we inhale as we do our construction, as we engage with brick molding, as we engage with all the related quarry dust extractive industries. And silicosis, on the other hand, cannot be treated. So it's important that we prevent silicosis. The next slide would have compared TB and silicosis and how it affects us. But most importantly, I think it's important that we know that silicosis cannot be cured, and in as much as TB as a vaccine is curable, silicosis has no vaccine and is not curable. So I would have also loved to speak about the social determinants of TB. That's the next slide. I'm rushing through because 0 minutes passed a minute ago. The next slide would have talked about the social determinants of TB, such that we cover and how we should address those social determinants of TB. So that would end my slide. And the next slide speaks to the sources where you can equally access more information around TB. There's a global TB report. That's the 2018 the WHO report. There's also the Zimbabwe National Population-Based TB Prevalence Survey. You can access more information on that. Then the Zimbabwe's first national survey of costs faced by tuberculosis patients, which was launched this year. You can also access more information from that, as well as from Ministry of Health and Child Care. And I want to acknowledge them as my sources for this presentation. Thank you so much.